This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
And then you have this ready-made online community, and they maybe have the same interests. Maybe they have a lot of the same disordered eating behaviours, and maybe can give a lot of positive feedback and validation in a really unhealthy way.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. The college recently released a new GP update, or GPU, focusing on eating disorders in December 2025. And today I'm joined by Dr. Aoife O'Sullivan, one of the authors of the GPU, to discuss eating disorders in primary care. Here's Aoife.
So my name is Aoife O'Sullivan. I'm a GP. I work in Cork. I work in the Student Health Centre in UCC. So a part of my role there is working as a regular working GP, but also doing a lot of mental health consults due to the age of the population I deal with, which are mostly 18 through to 30-year-olds. I also work with the Irish College of GPs as the clinical lead in mental health.
Aoife's in-depth knowledge of eating disorders is evident throughout our conversation, which I've divided into 2 episodes of approximately 25 minutes each, with part 2 also available now in the show feed. As usual, I've included chapter markers throughout to help you quickly find areas of particular interest to you. Today, which is part 1, we cover topics including the emergence and influence of online communities on potentially normalising abnormal behaviours more broadly, an approach to patients who self-present with eating disorders, some tips on picking up clues in the consultation that might lead to an eating disorder screen for a patient, as well as a review of morbidity and mortality data and the importance of early intervention. Part 2 picks up the conversation and includes an approach on focused examination, when to organise additional investigations including bloods, ECG and DEXA, an overview of medication options, when to refer to the emergency department versus specialised eating disorder clinics, as well as a review of some resources for patients and their families. And just before we get on to today's show, I wanted to quickly highlight my own experience with the college GPU format, in case you haven't had a chance to have a look yet. They're really clearly laid out, they're very desktop friendly, and they feature links on the front page to some of the most likely sections that you might need during a consultation. I found them really useful day to day, and I keep a folder of them on my own desktop. So if you haven't had a chance to check them out on the college website, I'd encourage you to do so, and I'll include a link to the list of titles in the show notes, along with links to all resources mentioned in today's show as usual. Okay, back to today's episode. Aoife began by reflecting on the impact of social changes since our own teenage years in the 90s with the advent of online platforms and social media.
Absolutely. I'm a child of the 90s as well, so I hear what you're saying. We're outing ourselves there with the age. And sure, the 80s and 90s were king of the diets, right? You know, the cabbage diet, cabbage soup diet and Atkins. Looking back on all that, this is not new. And we know that eating disorders like anorexia are described in literature going right back hundreds and hundreds of years. So none of this is new. What has changed, as you said, is the online communities that are so easy to join. So we know for young people, regardless of mental health or eating disorders, that, you know, there's been a massive kind of cultural and societal shift in the past maybe 10 to 15 years. So this is well pre-COVID, that increasingly their lives are lived through a computer screen and online, through various social media platforms. Now the social media platform will change, you know, go from MySpace onto Facebook, onto Instagram, and now onto TikTok. And I'm sure there's lots more that I don't even know about. So, but nonetheless, regardless of which platform it is, that there's a lot of social isolation involved with that, because your life can be lived through the screens and through the computer. And then we do get a lot of social isolation associated with eating disorders also, because if somebody has disordered eating or is worried about their body image, there's a little bit of a shift for them to move away from their families who are, pestering them to have their dinner, or maybe avoid social interactions with friends where food is involved. So they might be inclined to socially isolate that way as well. And then you have this ready-made online community, and they maybe have the same interests. Maybe they have a lot of the same disordered eating behaviors, and maybe can give a lot of positive feedback and validation in a really unhealthy way to these patients and these young people. And there'll be various names. You might hear groups called Pro-Ana, for example, Ana being sort of a name given to the anorexic voice. So Pro-Ana groups would be where you can join in an online forum, and they will be maybe exchanging tips and hints around diet, around restriction of calories, around exercise. And then a little bit more recently, there's a whole side of TikTok called Skinny Talk, which seems to be doing much the same thing. So each social media generation, which is quite short generations, have their own platform. And unfortunately for somebody who's grown up, as you say, as a digital native, which we didn't, it's extremely easy to fall into a little bit of a rabbit hole and think that this is really normalized because, that's the echo chamber that you can find yourself in.
Listening to you there reminds me of going back to the 90s and the noughts, being in pubs and seeing the lads who were sitting there all day. And on occasion, one of them might go to the GP. And it still stays with me, listening to some of those lads recounting what the GP or the hospital doctor said to them as a punchline. Lads, you'll never guess what he or she said to me this time. I told him how many pints I was drinking. You should have seen his face. And getting a round of applause nearly from his pub colleagues or her pub colleagues, because again, the social milieu was one where the clinician was the person with the problem, not the fellow with the pint in his hand. But that patient had to go to the pub to get his connection to his peers. I sometimes feel when I'm in primary care now that somebody is probably sending a message to their online peers just outside my door, just after I've spoken. And that's not eating disorders. That's more young people more broadly. And I know you're an expert in adolescent mental health and young people's mental health. Is that something that strikes you as well?
Absolutely. And on both counts, I suppose the interesting thing you said there about the pub is that we see, yes, the social contacts moving from pub situation online, for sure. The fact that you mentioned it was men is interesting because one of the, I suppose, stereotypes we can hold in our head is of an eating disorder patient being female, an adolescent girl, into gymnastics or modeling or fashion. Whereas the reality is that these disordered eating and eating disorders can equally well affect males. So they might be in the gym instead because there's a lot of body dysmorphia there, or they might be at local athletic club or track and field. So that's important. We do see that one of the reasons people do go to the pub a little less is because they want to avoid the calories in a pint of beer, and in fact we may be more likely to drink spirits, a vodka and Diet Coke type drinks. And as a mom of teenagers and as a doctor who works with young people, not very fond of that. I think that there's obviously a higher level of alcohol with, say, is it 40% in a vodka versus 10% or whatever it is in a beer. So it's not great in multiple areas to move, to be only looking at calories as your reason for socializing or not socializing, or in what way you socialize, that the body image and the calories take over so much.
Do you feel at times then that on the GP side that maybe we're at risk of maybe becoming a little bit dislocated from the real lives of our younger patients in particular? Like you're mentioning TikTok sites that feature eating disorders and disordered eating, and I'm hearing this for the first time. This whole other side of life is going on all around me with me being completely ignorant. And I guess part of my role as a GP is to have some familiarity with various parts of life.
Yeah, I some maybe, but I don't think it's an absolute necessity that we all, go deep diving into different types of TikTok. And I think we probably all do understand to a degree that you can end up in an echo chamber, whether it's a liberal echo chamber or it's MAGA on the American Cultural Front, that can happen. And we know that can happen, and that can happen to young people as well. So whatever, it doesn't really matter what the platform is, but knowing that people can fall into sort of unhealthy groups with an echo chamber, with their own thoughts being fed back to them about losing weight, about staying thin, about restriction, and the validation in that. So I don't think it'll be necessary as a GP to be like really up to date in every type of social media platform. I think, God, we've enough to be doing, but just being aware that that kind of thing can happen. And when somebody comes into their GP, if a young person comes into their GP and they mention something about being worried about an eating disorder, I think it's probably fair to say that unless they've been frog marched in by their parents, which can happen also, but if they voluntarily present, then they're probably quite a distance into that eating disorder already. I do think it's probably unlikely they'll come into you in the first couple of weeks of worrying about their body weight. That seems incredibly unlikely to me. I think in all likelihood, they are quite far down the pathway. So I think there's a few things that can be helpful there. One is if somebody comes in and they're hinting around it, or maybe you have your suspicions and you're kind of wondering, how do I even open this conversation with this young person? I'm saying young person here, it can be any age group. It can be people in their 30s, 40s, 50s, 60s. So I shouldn't really say, if you're talking to your patient and you think that you're worried that they might have an eating disorder, or you think maybe that's what they're hinting at but haven't said it out loud, the term disordered eating is really useful. It's sort of more acceptable, and it's not putting somebody into a box in the same way. So they might be more acceptable to the patient to talk about disordered eating while you're trying to explore whether this could be a fully fledged eating disorder or not, rather than jumping in. The other thing is that if a person or if a patient comes into you thinking maybe they have an eating disorder, I think generally starting point is to believe them, because you can have an eating disorder regardless of your body mass index, of your BMI. So BMI is an imperfect tool at the best of times, though it is still useful. It's not perfect. So you can have a situation, for example, bulimia nervosa or binge eating disorder, where somebody can have quite, bad disordered eating behaviors and compensatory vomiting or exercise, whatever it may be, binge eating disorder behaviors, and their body mass index and their blood tests, for example, might be absolutely fine. That doesn't mean they don't have an eating disorder. So I think, we can use all these different tools, but no one tool will show us exactly what's happening. Like a lot of mental health disorders, we really do need to take a good history and hear what the patient is saying to us and believe what they're saying. So in my experience anyway, if somebody comes into me as a GP thinking they've an eating disorder or worried they've an eating disorder, I will go with believing them and saying, yeah, that will start from there. And maybe they don't, but most of the time they will, regardless of a BMI being normal or abnormal.
We're now kind of, I suppose, making our way towards that general practice update that's newly available from December 2025. And if I could just take a step back from what you were saying there, we're already into a little bit of nuance, you might say, in terms of, is it an eating disorder? Is it disordered eating? Would you mind just outlining for listeners the difference between the two?
So I suppose when you look at an eating disorder as defined in the DSM, we have anorexia nervosa, bulimia nervosa, binge eating disorder, ARFID, which is avoidant restrictive intake disorder, and what they call OSFED now, which is an unspecified eating disorder. So they have 5 categories. And that, it's very useful to have, and they're very clearly defined in both the DSM and in the ICD. But for a lot of patients, when, like, as with a lot of illnesses, coming into a GP can be quite undifferentiated. It mightn't fall neatly into any, initially anyway, the behavior might not fall neatly into those categories, or it might be somebody who's maybe developing an eating disorder, but it's not clear. So if you think it isn't, the official term is the unspecified, the last one I mentioned there, but disordered eating is a really good place to start. If somebody's eating has become disordered, that is a good starting point for a conversation. And, we can take it from there then.
And just going back to your point about the importance of believing people, it's also worth emphasizing the incredible mortality and morbidity associated with eating disorders compared to other psychiatric conditions.
Absolutely. I suppose straight away we probably think about somebody with anorexia, because they are, for most of us, they're the kind of scary patients that we really, really worry about, particularly when their body mass index or BMI starts to drop below normal, but particularly when it gets very low. We can have patients with BMIs of 12 and 13, which is hardly believable, coming into our surgeries. And from a physical health point of view, that is very frightening to have somebody coming into your surgery like that. You'd be really worried about their physical health. So there is a higher risk of physical health issues with eating disorders. The anorexia, I suppose those patients, it's the most visible because it's really obvious that their BMI is low. When you check their blood pressure or their heart rate, you might notice, very low BP. They stand up, they might have a lot of, orthostatic hypotension and a low heart rate, a low, temperature. So all of those things. Somebody then with, maybe bulimia or binge eating disorder might appear much healthier, that their BMI looks fine. But maybe because if they have been vomiting, particularly with the bulimia, if they've been vomiting, their minerals, their potassium and sodium can be very messed up. So you can have a situation where somebody looks really healthy, but perhaps they're not. And then the other thing is that, in fact, even if those things are all okay, that there's a higher risk of deliberate self-harm or dying by suicide amongst this patient population when you compare it to the average person of their age group. So between all of those things, yes, it's definitely a worry.
And another thing that you highlight in your general practice update is the importance of early intervention and a multidisciplinary approach for improved outcomes. So taking action is really key.
Absolutely. All the evidence, and I suppose we say this in lots of areas, don't we? But all the evidence shows that early intervention really makes a big difference. And that is absolutely true with eating disorders. And I suppose we can become, particularly as we've just already outed ourselves age-wise, that we can have seen over the years people not do well and become maybe a little bit fatalistic. So now, as the years go on, we have more and more evidence to show that earlier intervention is important. Now, early intervention is only possible if there is systems in place where we can refer our patients to, so we can do our best as a GP to do an early referral, but totally acknowledge that depending on where you are in the country, because there's a good bit of geographical variation with specialised teams, that we can be all singing, all dancing about early intervention. It might not always be possible. But for eating disorders, when somebody has moved from a disordered eating behaviour into maybe what's a full-blown eating disorder, that the earlier you can intervene, the less sort of entrenched those thoughts and behaviours are, the more successful therapy will be in getting somebody back to a more normalised relationship with their body and with their food.
Okay, so Aoife, we're going to delve a little bit further now based on the GP update around history, examination, investigations and onward referral where appropriate. But before we do, you very usefully put a caveat into the introduction in your GPU around funding.
Absolutely. And as a GP, we already talked about how important it is to believe the patient that comes into you. We'll talk a little bit about doing a fairly straightforward history examination, maybe doing some blood tests. And they're all absolutely things that are very doable at primary care level. But when it comes to managing and treating an eating disorder, particularly something like anorexia, the evidence is that they need, for example, cognitive behavioral therapy, especially for eating disorders, which they call CBTE, and minimum of really 20 sessions of CBTE. To get that, we would need access to psychology or to CBT for most GPs in the country, direct access isn't an option and isn't available, and possibly isn't even available through the secondary services, but definitely not available to us in an easy manner, or for most people anyway. I'm being very aware that there's different services in different parts of the country, depending on where you are now when you're listening. So I think the reality is in Ireland that we do need to refer, and ideally refer early on, particularly if you're worried about anorexia, because we just do not have access to the sort of evidence-based therapy, which would be the CBTE, and the family-based therapy, which can be FBT, is the sort of acronym for that. And they are the therapies that have been proven to be helpful with eating disorders.
Okay, so given our limitations in primary care around resourcing and managing these patients and the requirement for referral to secondary care, I suppose it even emphasises the importance of a good history exam and appropriate investigations. This is all really nicely outlined in the GP update. And before we get into some aspects of the history, are there any kind of overall pearls that you'd like to share around an approach to patients who present where you're suspicious that there may be disordered eating or an eating disorder in the background?
Absolutely. So for a full rundown of the history that is in the GP, but just some important pieces that really patients with a very disproportionate concern about their weight or about their shape, and those that are really restricting. It's restricting their diet. It's really important to check into that. And you can ask that quite early on in a consultation, because you may well have a 17-year-old whose BMI is low, strictly speaking, but they're eating all around them, and they're very happy with their body shape, and they just have gone through a teenage growth spurt and they're tall and thin, or maybe they're genetically, their whole family are. So rather than just looking at BMI on its own, you're really asking them, are they happy with their body shape? Are they restricting? Are they over-exercising? And when you ask about over-exercising, you're asking about how frequently are you exercising, how many hours are you spending a day in the gym, how many times a day are you attending. So it's really about the intent rather than just about how they look or what their BMI is. Another thing that is useful to ask about would be, withdrawal, because a lot of people, as we mentioned already, can socially isolate or withdraw from situations, particularly if they involve food. And a lot of social situations in Ireland and in all cultures really are around, we've just gone through Christmas and it's all around the Christmas dinner or about the canapes in the relative's house. So a lot of it can be very food and drink oriented. And that can be a really challenging time for somebody with an eating disorder. And they might just end up just withdrawing socially or isolating themselves from their loved ones and from their friends. New dietary restrictions, somebody who suddenly becomes intensely interested in vegetarianism and then moves on to being vegan, or removing all gluten from their diet, despite the fact that they're not celiac. So, and obviously plenty of people are vegetarian and vegan for very ethical reasons, but it can be just a little warning sign to hang on, do I need to check this person a little more carefully?
You also mentioned before we started recording, Aoife, around the way some patients who have ongoing disordered eating may speak to themselves or may conceptualize your conversation with them internally versus what their self-talk after the consultation.
Yeah, I think this is really useful concept to have in your head when you're talking to somebody who has most likely an eating disorder, because it can be really frustrating. I can often find myself talking to this highly intelligent patient with me, and who's, agreeing with me that, yeah, they probably are restricting too much. Yes, they probably are going to the gym too frequently. Yes, their BMI is demonstrably low. And they're kind of agreeing with you, and you think, yes, they're hearing me here. And they walk out the door and they come back a few weeks later and nothing has changed. And that can be extremely frustrating as a working GP. So what I find really useful to think is this idea of the anorexia voice, or the ANA voice, a lot of them will call it, which is a separate eating disorder voice that's really strong in their mind. So you almost have sort of visually imagined somebody's brain, and half it is this logical brain, because a lot of the time, highly intelligent, very focused and very driven individuals with a logical brain that understands on a logical level that this behavior is not healthy, and that they can agree with you and see that it's not right. And yet the other half of their brain is the pro eating disorder voice can be so strong. And that voice is telling them, you need to restrict more, you're getting fat. Isn't it great your BMI has dropped, another few points since last time you saw the doctor, even as they're telling you that they're unhappy, secretly they're happy. So this pro eating disorder voice can be really loud. And when a patient is sitting in front of you, they can be quite conflicted, that logical half of their brain versus the eating disorder part of their brain. And if you ask them about it, they'll sort of agree with you. Yeah, that's what I'm hearing. And when I walk out the door, the part that takes that loudest voice in my head is the eating disorder voice. That voice drowns out those logical thoughts about healthy eating that we just discussed, because that voice is the one that they're listening to, and that is overwhelming for the patient. So I think if you kind of have an understanding of that as a GP, that these persons' thoughts have become very irrational, very distorted, and very extreme, and there can be a lot of black and white thinking, and that all goes with poor nutrition, because they actually have malnutrition. So if you can understand that, I think it does take away some of the frustration for the GP, and it helps the GP understand the person that's sitting in front of them and why they might be nodding and agreeing with you and walking out the door, as you already mentioned earlier, walking out the door and completely ignoring everything that happened. It's not really intentional. It's that the eating disorder part of the brain is just so overwhelming and is the loudest voice.
And listening to that, it's easy to imagine the busy GP sitting in front of a patient who's telling them everything they want to hear and saying to themselves, okay, we can handle this ourselves and we can actually manage this. But going back to your earlier comments around morbidity, mortality, and the stakes of not intervening in a multidisciplinary fashion, it's important to recognize, I guess, your limitations, and if there's a suspicion, to have a low threshold to refer.
I agree, and I've fallen into that trap myself many times, because up until extremely recently, where I work in Cork, we didn't have an eating disorder service, an adult eating disorder service. It opened just very, very recently. So there wasn't really a good, specialised service to refer to. And often our patients, again, working in the university sector, they'd be extremely, they're extremely intelligent young people who would be absolutely agreeing with you and say, no, I'll definitely do better this time. I hear what you're saying. I'm going to go away and do all the right things. You think, yes, we've gotten through to them where this is all going to work, and then come back, 3 or 4 weeks later, and unfortunately no weight gain and maybe even some weight loss. So yeah, and then you find that actually you've been colluding, unintentionally with the patient's best wishes at heart, that you've become colluding with them in this disordered behaviour. Yeah.
Many thanks to Dr. Aoife O'Sullivan for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. And as a reminder, part 2 of this conversation is also available now, so please have a listen, and you'll find it in the podcast show feed. If you have any comments or feedback on today's show, or indeed suggestions for future episodes, please let us know. You can contact us at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.